Okay.
Glad you were able to come down. Travel plans go okay?
Yes. Yeah. Everything went fine. So.
Everybody, take your seat, please. We need a bigger room. We got room in this room. Okay, we'll go ahead and get started. Please take your seats. Before we introduce our Grand Round speaker, I have one announcement. This Saturday at the AB site, our residents elected their administrative chief residents for next year. I'd like to congratulate Jason Fluke and Joe Love for accepting those positions.
Thanks, Dr. Dent. It's my pleasure to introduce our speaker for this morning, Dr. Jorge de la Torre. George is a native Texan, originally from Houston. He did his undergraduate at the University of Texas in Austin. Went to medical school at the University of Texas Health Science Center at Houston, and did his general surgery residency at St. Joe's. Went on to do plastic surgery in Long Island and a breast reconstruction and aesthetic fellowship at UAB Birmingham, where he's been since that time. George has been extremely productive academically. He's been a leader of the program there and is currently professor and program director at the University of Alabama at Birmingham. Dr. de la Torre is going to speak on a comprehensive approach to the abdominal wall. Dr. de la Torre.
Well, thank you for that introduction, and it's really a pleasure to be here. And I hope that what I have to share with you today will be of some use, and it won't be too esoteric. But this is something that kind of came about in my practice as I started right out of my fellowship, seeing patients for a variety of different reasons, and I ended up seeing a lot of patients with abdominal wall problems. And one of the things that I find interesting is that it's a spectrum, everything from trauma laparotomy patients to patients who are coming in for liposuction. It really isn't a spectrum. And as a plastic surgeon, at least the way I was trained, we use all the tools that we have in both arenas, or both ends of the spectrum, whether it's a patient who comes in and you say, why are you going to operate on that perfectly healthy, normal-looking patient who wants to get rid of a little something after they've had a baby, to this other person who's still in the ICU and they're not going to let you operate on them for another few weeks. But the tools we use, I think, are similar. And in fact, we like to take from one area and put it in the other area, from the trauma patients to the cosmetic patients, and the cosmetic patients to the trauma patients. So as I go through this, what are we talking about with abdominoplasty? Well, it really means to reshape or remold the abdominal wall. And while if we watch TV, it looks like it might be liposuction, or it might be cosmetic abdominoplasty, might even be paniculectomies for patients who've had bariatric surgery and had significant weight loss. But it also includes patients who require soft tissue coverage and patients with ventral hernias, or abdominal wall hernias. In fact, I see quite a number of patients with ventral hernias, and I'd like to share a little later on some of my experience with these patients and some of the ways as plastic surgeons we approach it. But if you look at this patient, I think this is a patient who might benefit from some sort of abdominoplasty type procedure. But I think when we think about assessing this patient, we really see there are a lot of issues involved. We look here, the skin is problematic. It's stretched out, it's thin, it's becoming excoriated here. Certainly we've got a problem with the muscle and the fascia being disrupted, the large hernia coming through. So it's really a lot of levels that are involved when we see a patient like this. And so what I'd like to go over today a little bit is the abdominal wall, some of the anatomy, which I'm sure you all are familiar with, but I'll hit some highlights, some of the physiology, which might be a little bit different way of thinking of the abdominal wall, some of the pathology. We'll go through some cases, reconstruction, abdominal wall hernia, and then, of course, it wouldn't be a plastic surgery lecture if we didn't talk at least a little bit about aesthetics, so we'll touch on that at the end. Current techniques that we use in particular for soft tissue coverage but to reconstruct the abdominal wall include, in some cases, simple primary closure. We may use staged repair techniques, and I'll touch on this a little bit. Use of prosthetic materials or other artificial materials, and certainly that is an area that's continued to change as we've seen progression from simple prosthetic mesh materials to the biologic materials and the decellularized dermal type materials. Rotation flaps, and this includes not only local flaps but even free tissue transfers, which on occasion we'll use. And then probably the most helpful tool that we have at this point is the abdominal wall advancement, the rectus advancement, or the component separation type technique. Just to touch on some of the anatomy, again, this is important for us, particularly when we're talking about moving muscles or flaps around, that we're cognizant of the superior inferior epigastric blood supply. Of course, we've got the superior epigastric blood supply, and those are important when we look at the rectus muscles. But I think it's also important to be cognizant that there is some additional blood supply, both from inferiorly and from laterally through the intercostal arteries, that help supply the abdominal wall. And I think that's important also when we look at patients with previous incisions and how we're going to approach those and how we're going to be concerned with the blood supply being impaired. Of course, the venous drainage kind of matches the arterial supply. We want to be cognizant of the nerve supply as well, because particularly with this lower type of incision, we do see it not frequently, but we do see on occasion patients who have some sort of nerve entrapment, and that can really be problematic for them as we try and correct that problem. Musculature, and this is really where we get a lot of the material that we use for reconstruction of the abdominal wall. You can see the rectus muscle peeled back. You can see the abdominal wall and the various layers, and that's important as we talk about component separation or some type of component separation operation. We're actually separating some of those layers so that we can move things together primarily towards the midline. And I think it's important to be cognizant of the innermost layer, transversus abdominis, because really if this layer is intact, you can't have a hernia. Doesn't matter what's going on in the rest of the area. If this layer is intact, it's going to keep the insides in, and it's going to provide adequate protection. But the alignment of the muscles is also important. And if you look at this patient here, and you can see the rectus muscles out with this large diastasis and a hernia here, they're really not in proper alignment, and that's really going to impact the patient. I think it has an impact on risk of recurrence, but when we look at the patient now corrected with the rectus muscles in the midline aligned properly so that as tension is applied, it actually contracts the abdominal wall rather than pressing the hernia out. Fascial landmarks, and again, probably the most important point here is to be cognizant that the posterior rectus sheath does end at about this level at the linea semicircularis. We won't belabor the fascial landmarks too much. I do think it's important that when we talk about myofascial continuity of the abdominal wall, we keep in mind all the contributions that it makes. It certainly keeps the insides in and the outsides out, but it also helps with variations of intra-abdominal pressure, which is important for a number of activities. It also helps with respiration, and it certainly contributes to posture. And I'm going to touch on this just a little bit more. This is something out of the plastic surgery literature, and Dr. Toronto, whose son is actually at UAB as a general surgery resident, did some of this work early on. And he was looking primarily at patients who were undergoing cosmetic abdominoplasty surgeries. but he would tightly plicate the diastasis that they would have and really bring the rectus muscles together. And he called this the wide abdominis rectus plication technique, or the warp technique. And one of the things that he noted was these patients would come back and say they had relief of their back pain postoperatively. Well, he was working on their abdomen, trying to make them look a little bit better. Why would their back feel better? And it really helps realign the rectus muscles so that it improves the posture, and it, in this case, really helps some of these patients with their postural back pain. I don't want to spend a lot of time in this on this point, but just to touch on it, he actually looked at MRIs of these patients and saw that there was evidence of reconstitution of the disc and that there was increased vertebral space, more objective findings that would be consistent with improved posture. And this isn't something that's been studied a lot in the plastic surgery literature, but in the orthopedic literature, they do look a lot at the biomechanics and how alterations in the angle of the muscle and the lines of tension really affect function. And it's really impressive that a little deviation of the muscle really affects how the back works and how the back is aligned. So I don't think it's unreasonable to expect that we're going to see the same in the abdominal wall. So I think these lines of action really are important. Now let's talk a little bit about abdominal wall defects, and you know, it's pretty simple really. It can be skin, muscle, fascia, or a combination, and a lot of times when we're involved, it's a combination. But also it can be an excess of skin, and then finally, of course, aesthetic deformities. Etiologies, I think pretty obviously. Congenital, I don't see a lot of congenital problems because my patient population is almost only adults, but certainly traumatic, iatrogenic, and infectious problems are something that we see quite a bit of. What do we do with these large defects, particularly traumatic defects? Well, you all probably have done this a lot more than I have recently, but there's a number of ways that we can, in the acute setting, address patients with trauma laparotomies and abdominal compression problems. But Bogota bag would be one option. Whitman patch might be another alternative. A vac pack, or certainly now we've got more advanced negative pressure wound treatment systems that we can use that achieve the same goal. I think this is probably a pretty nice way to address this problem because you end up not only helping some of the edema resolve, but I think you also keep some tension on the abdominal wall itself. So while you're not actually performing tissue expansion, you are keeping that tension on that abdominal wall. I think it ultimately facilitates closure. But we do see patients that we're not able to get closed initially. This is a patient one of my residents was able to share from his experience during his trauma training. But you can see here, not atypical, a patient with a large abdominal wall hernia and skin graft. Well, if we can get this patient put back together and lined up, not only will help their function, we'll get their tattoo lined back up, and he'll be happy with that. But this is another complex problem, and this might be something that we might see just as often. And here you have a patient who has a abdominal wall fascial defect, and you can see separation of the rectus muscle here. There's a skin problem, and we've got this open wound, but made even a little bit more complicated by this ostomy over here on the side. And so we have to take into consideration how we're going to move the rectus muscles. What are our options to address this? How do we want to proceed? Is this something that we can address at a single setting, or is this something that we need to be perhaps address a little bit more slowly and do in a staged fashion? And one of the options that we might consider for a patient like this or some similar patient is to use, for example, a rectus femoris flap, where we might bring up this myocutaneous flap and provide some coverage. Now, this does have some advantages in that in a single stage, we're able to bring in some vascularized tissue. We can actually bring in all the components that we want, and that we can bring in the skin, the muscle, and we can even bring in fascia so that we can get things put back together. But there is some significant donor site morbidity, and you can see here from another patient with a similar type flap. But our options, are somewhat limited to really reach the abdomen, but the latissimus dorsi, we can use the rectus abdominis, we can advance, and we use that quite a bit. External oblique, somewhat limited. Tensor fascia lata, again, to actually get it up into the abdominal wall can be somewhat limited. Rectus femoris works well. Free tissue transfer is something that we may have to consider as a last resort. Big operation, especially for the abdomen, but something we might need to do to bring in all the various tissue layers that we need. Again, advantages, single stage, composite, and in some cases even we can perform a dynamic reconstruction, which I'll touch on. I think that's really an important component of reconstruction, the dynamic component. Disadvantages, really donor site morbidity is not insignificant with these types of flaps. Stage reconstruction would be another alternative, and you can see here a patient who underwent skin grafting to kind of temporize things with a relatively small hernia. The fascial defect was addressed, and a fasciocutaneous flap brought up to provide coverage on the skin graft area, and worked quite well in this patient, and it probably improved the aesthetic appearance as well, but not always an option for everybody. And stage reconstruction can, in many cases, be very helpful. It can be relatively simple. It can allow us to bring in similar tissue, but it does require adequate perfusion in these various areas. In some cases, it can be unstable in that we're asking the tissue to move too far. We can have issues with adhesions, particularly if we're talking about placing mesh in a skin graft initially. Then to go back and remove that mesh and skin graft can be quite difficult. And in the interim, the patient really has no structural integrity in that they have this large skin graft and mesh area which is hanging out. And these patients, unfortunately, always, by design, require reoperation. Tissue expansion, however, is a variation which is a little bit different with regard to staged reconstruction in that we don't necessarily need to proceed with a temporizing use of mesh and skin graft. And in similar fashion, we are able to use the patient's local tissue. It decreases donor site morbidity. And this has been described by a number of people. We won't go into that too much, but you can see here an example of a patient with a large defect. And you can see the expanders in place and how they've stretched out that tissue. That then we can advance to the midline and get closure. And you can see here the tissue coming together and closure here. And not a lot of donor site morbidity necessarily, so, I mean, that sounds like a great plan. And there are a lot of advantages to this type of approach. Certainly it's simple. We're using the patient's own tissue. It can certainly be a dynamic reconstruction because it's local tissue. It's durable. It minimizes the aesthetic component of donor site morbidity and certainly the functional component of donor site morbidity as well. Unfortunately, it does require multiple stages, and these patients need to come into clinic and have their tissue expander inflated over time. It can be painful, and there can be complications not only from the reconstruction but from the tissue expanders themselves. They can erode through and have to be removed, so that can be a problem. I'm going to talk a little bit more specifically now about abdominal wall hernias and how we can use the local tissue without these stage-type procedures. It's a pretty common problem. We see it in a number of patients who have abdominal wall procedures. You can see that 10% of patients can end up with some sort of ventral wall hernia. And I think this is something that's pretty interesting. 30 to 50% recurrence rate. Now that's with primary repair, and that's been described in the literature, but it's kind of amazing to think we do operations that half of the time don't work. So what are our goals with abdominal wall hernia reconstruction? Well, of course, we want to keep the insides in. Again, we would like to obtain a tension-free repair, that is, where we actually repair the hernia defect is not under tension because it's going to have a high risk of recurrence if we repair it that way. We would like it to have a dynamic muscle support. I think that is very important. I've alluded to it a little earlier, but if we can get those muscles back where they're supposed to be, they're going to work the way they're supposed to. If we can do this in a single stage, it's better, and if we can, of course, minimize morbidity and even postoperative disability, I think that's important. And certainly there are a number of complications that can occur with patients who have hernias. These are probably areas that in general surgery you're going to see much more than the patients I see, but this is a significant problem. This is most of the patients I see, this is what they come in with. I can't pick up my grandchildren, or I can't work, or it hurts when I do just about anything, or I have to wear this corset, which is uncomfortable. And so it's really a lifestyle issue for most of the patients that I see, but you know, it's not insignificant. Now, when we talk about hernia reconstruction, again, we've got options of primary closure, although perhaps that's not the best way to proceed. Staged repairs, again, we've gone over that a little bit. Prosthetic materials, and I'll talk about this just a little bit more. As I said, I think there certainly are a number of options that are available. There's many cases when prosthetic materials, Prolene mesh or whatnot might be the best option, but I think in most of the patients that I see, we look for alternatives. And I think we do have a number of alternatives now. Rotational flaps or component separation type technique. And again, looking at the literature, we can see that primary suturing of the fascial defect has really been come under criticism, and we can see that really the risk of recurrence can be quite high. One of the interesting things when we look at primary suture repair is versus mesh repair is that some of the criticism really isn't based on the size, it's really just on the type of repair. Now, here's an example of use of prosthetic mesh for repair. Now, I think something interesting in this case is you see not only is the mesh placed behind the muscle, but it's kept away from the intestines. It's protected there. We have this nice layer. But if you look in this picture, they have the muscles almost back together. Well, I think that's an important component. You get the muscles back together, I think you're much more likely to avoid risk of recurrence. And I think this technique works so well because it really takes advantage of some of the physics involved, and it just makes a lot of sense. If you have this mesh placed retromuscular, as you increase intra-abdominal pressure, it actually helps adhere your patch to the back of the abdominal wall, as opposed to a non-lie patch, which actually, with increased abdominal tension, is going to be stressed and strained and weakened. And so you can see Stopa's description of his technique, and you can kind of get an idea of the size hernias he used. 133 were large, that is greater than 10 centimeters in diameter. And you can see here when he used mesh, 86%. He describes also performing this repair without mesh, and I'm not sure what he used instead of mesh, but it wasn't as effective. And when we look at using large mesh material for hernia repair, you can see here some of the recurrent rates reported are quite low, and in fact, this is kind of the dogma in the literature that experienced surgeons should use retromuscular prosthesis to repair not only large but all incisional hernias. And that's fine, but using mesh is not without its problems. And in fact, we do see, although you might decrease your risk of recurrence with these types of repairs, you do increase your risks of other types of problems. Fistulas can be very problematic because now you've got a contaminated wound. You've got prosthetic material. How are we going to address that? We've got to remove the prosthetic material, fix the fistula, and then come up with a plan to reconstruct the abdominal wall. And that can be difficult even if we have adequate tissue because we want to avoid the contamination. Infection, extrusion of the mesh, also problems that are seen. So, and you can see here, what are risk factors for complications? Well, prior infection, recurrent hernia, probably one of the greatest risk for recurrence is that this is a multiply repaired hernia. And then this is another problem in patients who've had multiple laparotomies. You get in there and you really don't have any momentum that you can use to line that mesh, and so you've got the intestines directly next to that prosthetic material. Some contraindications might be if skin coverage is inadequate. Certainly permanent mesh is not going to be a good choice. Patients with fistula, any type of aggressive infection in the abdominal wall needs to be addressed before you can think about putting the fascia back together. Exposed prosthetic material we have to assume is colonized. Contaminated wounds and colostomy sites also problems. So if we can use the patient's own tissue and avoid the use of plastic, it can be advantageous. And this is basically the idea behind the component type separation. There's a number of various descriptions. Dr. Ramirez is the first in our literature to describe it, but certainly others, Sam Sukar in Houston, Dr. Fabian has his own approach to this. And I don't think the exact technique is very critical. I think it's the principle involved here that's important. If we can, by releasing the fascia here, by unfolding this area, get the rectus muscles back in alignment in the midline, we can avoid the use of prosthetic mesh, and we can get a nice dynamic reconstruction. I include this. I talked about prosthetic mesh a little bit and some of the alternatives. This is from a particular acellular dermis, but one of the nice things about these materials is you can see that if we use this material, it actually becomes revascularized and incorporated into the patient's own tissues. For a time, I was using some of the absorbable meshes for some of these repairs. And although we don't have it in any of the clinical literature, we have seen in some of the animal models that use of these absorbable meshes actually decrease wound healing potential and decrease the strength of your repair. So I've really gotten away, if I can avoid the absorbable meshes as well as the permanent meshes. And I think this is a nice alternative if you do need some sort of interpositional patch or some sort of reinforcement. And I'll show you a little bit how I use this. We looked at our data and we did kind of a retrospective review of a number of patients who had hernias. We actually looked at, we did a number of studies and we looked at various approaches. I'm going to talk primarily about what we call the abdominoplasty approach, but we looked at this in bariatric patients. We looked at it using various mesh materials, and I'll go over some of that data. But this is kind of our experience, and this is when I joined the faculty, and you can see we really saw an increase in abdominal wall hernias. It was interesting. For a time, we saw a significant increase with the bariatric patients, but with the endoscopic approach, we've seen almost no hernias. I think with the open approach, my guess would be well over half, probably the majority of patients would develop some sort of ventral hernia. With the laparoscopic approach, it's very few, if ever, that we see hernias. But certainly we see an increase in the patients that we're taking care of in our practice. And just to give you an idea of the patients and what we're talking about, you can see the breakdown by gender and age, BMI about 32, and certainly there were a number of bariatric type patients that we saw. You can see contaminated cases or cases that their original surgery was emergent, or and most of those would be trauma laparotomies, and then a number of patients who had wound infections. Hernia incisions were in the midline the majority of the time. Again, 2/3 were primary, but we did have about 1/3 that were recurrent hernias. Some that were recurrent for us and some that were recurrent and came to us originally as recurrent hernias. About 1/3 had mesh present when we saw them, but I think this is important too to look at the size. We're just not talking about 6-centimeter hernias. I mean, these are fairly large hernias, and you can see 3 by 4 centimeters up to 30 by 50 centimeters. And this is a breakdown of how we address those patients. In 83%, we were able to approximate the fascia again with whatever technique we used. Now, in some cases, we call this primary closure, but this really is a muscle muscle advancement, but primary approximation of the fascial defect, and we used a non-lay patch. And as I said, at one point we were using Vicryl to reinforce this, but we switched to the decellularized dermis, which I think has many advantages. And I'll touch on how my thinking about using this type of patch with this type of repair when we get to some cases. You can see we used muscle advancement or a true component separation about 6% of the time. We had about 12% of the patients that we were not able to advance the rectus sufficiently, and they ended up with a patch or an interpositional type patch. And I think this is problematic, and when we looked at our numbers, we found that indeed that was a problem for us. And we had a few patients that we would have to bring tissue in from somewhere else. And when we look at the recurrence rates, you can see fairly good recurrence rate in smaller hernias, and even where we advance things and plicated with an on-lay patch, or if we use the muscle advancement alone. But when we look at myofascial gap or an interpositional type repair, suddenly a significant difference, 31% recurrence. And these are a little bit, the size is a little bit different between the two groups, but it's not too significant. And even when we look at these larger groups, when we're able to advance the muscles or use a flap, we were able to get a much better, a much lower recurrence rate. I think this is kind of what we glean from that. There certainly is a higher morbidity in the patients with the larger hernias. They're going to have larger operations. And I think we've kind of self-selected out patients with bigger problems. With the smaller hernias, the recurrence rate was the same, whether we advanced the muscles, regardless of how we got the muscles together, using a component separation or just a muscle advancement. And certainly for the larger hernias, as I indicated, when we were able to restore myofascial continuity, the risk of hernia recurrence was lower. And just a couple of examples in how we approach this patient. You can see this patient, large pannus, old midline incision, and you can see what we've done here. What we'll do is we'll use a lower abdominal wall incision, and we can dissect up around the hernia, and we're going through clean tissue planes rather than dissecting through the old, up and around the old hernia sac. We can get completely around the hernia sac in this fashion, and then we can add a midline incision if we need to, but we don't necessarily need to use the midline incision. In this case we did because we wanted to remove the old scar and there was some excess skin. But then we can remove the mesh, and then we can, in fact, remove the pannus. And I think that's helpful in a lot of these patients. If we can safely remove the pannus, we can decrease some of the risks they have for wound healing problems. We get all this intertrigo taken away. We get that area that remains moist, and it's problematic for wound healing. So I think that's helpful. And this is kind of a breakdown of some of the risk factors in our patient population, but you can see a number of them were obese or had recent weight loss. There was a number with diabetes, immunosuppression, and you can see some of these others for yourself. So we didn't cherry pick just the healthiest patients to include. In about half the patients, we were able to use that lower midline incision alone. In just a smaller number, we did use the inverted T, and we used that inverted T for a number of reasons. In some cases, it was for better exposure, although I think we can get adequate exposure in most of these patients with the lower transverse incision. In other cases, it was because the quality of the skin was problematic or there was excess skin. And this is just an example. You can see using, and this is, this is almost like doing an abdominoplasty to describe it. We've used a lower abdominal wall incision. We've elevated up the abdominal wall flap, and we have brought the two rectus muscles back together in the midline. And you can see here another example of a patient, and I include this because it doesn't allow, I think, a little bit better visualization with the T-type incision. But you can see we can use this incision to do our dissection. Then we can make an incision just through the skin flap. We've isolated the hernia defect, and we've defined it. Now, in this case, we did more of a true component separation. It was a large defect in an obese patient, and it was difficult to get things together without tension. But you can see we've released the muscles laterally. We've gotten the rectus muscles back together in the midline. Now, I think that's important. Here's another example of a patient with a fairly large hernia, and I'll talk about how we use this, but you can see here's the hernia. Now, what we have done actually in this case is we've brought the rectus muscles together. What I typically will do is I will primarily repair that hernia defect so that we don't have problems with an internal type hernia. But that's not the hernia repair. The hernia repair is actually bringing the muscles together over the top of the fascial approximation. So once we've obliterated that space where anything can come through, then we can advance the muscles together. Now, how do we determine whether we can advance the muscles directly, whether we need to use a component separation, whether we need to release the rectus sheath? That's a little bit more difficult. I can go over that, but typically it takes us about 2 years to teach residents how to do this, so we won't go into all of that this morning, but there's a lot of practice and knowing how tight can we advance this. How tight is too tight? How tight is too tight for the patient? Because we have issues with pulmonary problems or other issues, so we have to keep track of that. But in this case, certainly we can bring the rectus muscles together. Now, in this case, we also used an onlay patch. What's the purpose of this? If we put a patch over the top, that's not physiologic. We just, earlier on, we kind of critiqued that technique. But this isn't a patch to repair the fascial defect. In fact, what we're doing with this is we can now get good purchase on the lateral portion of the rectus sheath. And this is more of an imbricating type patch. We put this together and we actually tighten this and decrease the tension that we put over our imbrication and plication layers here. And we have good tissue that we can sew to, and I think it works quite well. And even if this doesn't last in a permanent fashion, if it will help disperse the tension along the abdominal wall out laterally a little bit further, I think it really helps with these patients. Now here's another patient with radiated skin, multiple incisions, really could not advance this patient any further. This was I think this was a patient that had an APR, and we ended up doing a reconstruction, or they ended up reversing the colostomy. I can't remember what happened with this patient, but bad skin, bad soft tissue, really could not advance it. Now you can see here what we've done is we've simply sewn a patch in. It goes underneath on either side, but we've got a patch here and we've got a gap between the two rectus muscles. That's a problem. I mean, that's just not an ideal repair. Now, in this case, it allows us to get things together. It allows us to close the abdominal wall, but in my mind, this is not an ideal reconstruction. Now, when we look at complications, you can see local complications in about 28%. Now, this did include some minor wound dehiscences or necrosis at the skin edge, but it also included a patient or a couple patients with fistulas, some patients who had retained mesh, which became infected, one patient who had extrusion of mesh. So, some of the problems weren't that insignificant. The systemic complications also we've got to keep track of. Ileus is probably the most common problem. Certainly when we tighten things a little bit, that can be problematic for patients, but we also make sure we take care for DVT prophylaxis. And this is something I check all the patients. I actually now do pulmonary functions on the patients in addition to screening them when I talk with them to make sure if they've got some chronic underlying pulmonary disease, if it's significant, they very likely may have problems after this type of surgery. If we end up tightening them and increase their abdominal wall pressure just a little bit, they end up with pulmonary compromise. So that's something that I think very important to be cognizant of. However, if we can avoid the use of mesh, and in this case we actually had decellularized dermis as a reinforcement for our repair, we can really decrease the problems when we do have these wound complications. And you can see here's a patient, and you can see this dermis is revascularizing. It's red. It's healing. We can do some negative wound therapy on this and get this area to close. or we can do some dressing changes and it should close up, and we don't have to worry about exposed mesh, removing that, getting them all cleaned out, and then starting back at the beginning of the reconstruction. And just a couple of examples. This is a patient just with a hernia, a small pannus, which we removed. We did use a vertical incision as well, but we were able to, as you can look here at the contour of the abdomen, address this large diastasis in the small hernia to get her repaired, and I think help her out a little bit. So I think if we can reapproximate the fascia, we can either reinforce it with plication or one of these onlay grafts, and when we need to, we can use fascial partitioning or release, and last-ditch effort, interpositional patch. Another patient, bariatric surgery, large abdominal pannus with an epigastric incisional hernia. In this case, we did use the vertical incision also to remove some of the excess in the midline, but I think we helped her out. She certainly felt better about the way she looked, but she worked better. She functioned better. She was able to increase her activity level and get back to work and felt better doing those things. So I think that's important. So I do think this technique can be helpful. I think if we're able to do it properly, we do have a low rate of recurrence. I think it's helpful for complex hernias, these large hernias, multiple hernias, even recurrent hernias. The complications are usually relatively minor in that they don't require reoperation, and we're able to avoid prosthetic mesh. Using this type of approach, I think we do get good exposure. In the past, when we were using some prosthetic mesh on occasion, we actually would keep the incision distant from where the mesh would be placed. That is, using a lower transverse incision and placing the mesh in the central portion, even if there is a superficial wound problem, it's not going to be directly over the prosthetic mesh. But as I said, we've really tried to avoid the use of prosthetic mesh. And of course, again, we're plastic surgeons. We want to improve the cosmetic outcome. Now, I just want to finish up with a couple of those types of cases because, as I said, I think it's similar principles. And I think the way we decided to approach these reconstructed patients came from what we were doing with cosmetic patients. And you can see here a patient, no hernia, but a significant diastasis of the abdominal wall. Now, the fascia is intact, but you can see here the difference when we plicate the rectus and bring it back together, and primarily to improve the appearance, but certainly the patients do feel a little bit better. And I think it's interesting, certainly we've got a long history of these types of patients, and when we look at the patients that have problems with their diastasis repair, we don't see that. These patients, once we repair them, plicate and imbricate them the way that we do with abdominoplasties, this is a lasting and permanent type repair. And just an example here where we've outlined, this is what we're going to plicate in a patient like this. So we'll advance the rectus muscle that far. And you can see we're all the way up to the xiphoid through this lower transverse incision. And we covered that a little bit, but I do think one of the things is with complete fascial closure, if we can dissipate the tension off of the fascial repair, which is what we're doing. We put the fascia together, then we imbricate and plicate. So actually the hernia repair is not under tension. The abdominal wall is under tension, but it's a dynamic repair. I think we really can decrease the risk of recurrence. Just a couple more patients I want to get to, and you can see this patient also with some breast surgery, but this is something else I just want to kind of finish on the bariatric, because we do see an increasing number of patients who are having bariatric surgery and an increasing number that are making it to us for whatever they want to have done for primarily the abdomen, but other areas as well. And these patients, they just want to fit better. Primarily, they want to fit better in their clothes. They want to feel better about what they look like. They want to carry out their daily activities. And a lot of them come in very surprised. They say, if I would have known that I was going to look or feel like this, I would have almost rather not lose all the weight. I mean, this is as bad. I still feel fat even though I weigh less because I've got all the stigma from a fat person. And so a lot of these patients really are motivated. I think this is one of the things I really look for. patients that come in and say, I want to look good in a bathing suit, or I want to, be pretty. These are big operations, and these are in many ways more reconstructive than cosmetic operations. But patients that come in and say, look, I can't put clothes that fit my arms don't fit the rest of me, or if it fits my abdomen, I can't. These are patients that really have problems that we can address. And we've looked at addressing these patients on an outpatient basis and found that once we get them down under a BMI of 30, we're really able safely to address these patients on an outpatient basis. And you can see here a patient not only with abdominoplasty type approach to contour her abdomen, we also addressed her breast and did a reduction. And subsequently, she's had multiple other procedures to address other areas. But, that's something that's been able to help her in the decision she's been able to make on how she wants to proceed. I'll just finish up with this, but I think the objectives of abdominoplasty, at least how we approach it, are, number one, to provide adequate coverage, because that's the most important thing. Patients with open wounds are a big problem. So if we can get them closed, that's my first goal. The next thing we'd like to do is get the abdominal wall back together. Ideally, we will do this with a dynamic muscle type repair, because that's going to give the patient the best function. But we will take restoring the muscle wall or the fascia any way we can, as long as it will reduce the hernia or the defect. Of course, we want to reduce or minimize morbidity and the recurrence rate. And I think this is something we need to continue to be critical about, recurrence rate, because it really is surprising when you look at the literature and the recurrence rates that some people talk about, how high they are, and that we don't rethink how we address this patient population to try and decrease that recurrence rate is sometimes surprising. And then, of course, we want to restore the landmarks with an aesthetic approach if we can. But that's really what I have, and I'd be happy to take any questions if anybody has any. Yes, sir.
Got a couple of questions. Actually, I was wondering if you could go back to the slide where you showed the two patients where you did the low T incision.
The low T incision.
Because the post-op picture shows no vertical component, or it shows that you drew like you were going to do a T, I guess. But there's no vertical component to the scar. Yeah, that one.
This one? No, we did not. We did not.
I was looking at the drawing on the right or left.
Sure. No, it's marked out. That's more the diastasis, and it has to do with the liposuction that we're going to do in that. We did not use a vertical incision on that one.
Okay, and then how does a right or left subcostal incision alter your approach? Because once you've transected that superior epigastric,
right,
I'm assuming that changes things quite a bit.
It does. And that's a significant problem for two reasons. One, we've got problems with using the rectus muscle on that side, obviously. Now, sometimes we can advance that over, bring it more to the midline, but we've got problems we've got to make sure we preserve that inferior blood supply. That's sufficient for the rectus muscle. I mean, we will not infrequently, for example, to reconstruct an APR, we'll just bring it off the inferior epigastrics and drop it down through the perineum. So that's going to be sufficient for the rectus muscle. The real problem is the skin. And we really don't want to undermine the skin off of that rectus muscle, or we're going to have problems with it. I mean, you can, but you've got to be very cautious on how you do it. And I try and avoid it, but there's times that we will do that. Now, the costal blood supply, as long as we preserve that lateral portion, we can do it. Sometimes we'll do something we call discontinuous dissection, where we will undermine some of the soft tissue, but actually leave those perforators intact, and we'll get some advancement that way. But it's a significant problem. Yes?
Excellent talk. I'm not certain I fully understand. Whenever I looked at your abdominoplasty series, and I think you know that we fairly liberally, for big abdominal wall defects, use separation of components to basically mobilize the rectus. And so that all makes sense. But whenever I look at your series, you only use that, I guess, that formal technique in the minority, it's like 6%.
Right.
talk about moving the rectus muscles in normal anatomic alignment. Are you doing some hybrid of just releasing the posterior sheath or the external oblique, or how are
Exactly. Well, I think it kind of depends on the patient. I just think the formal component separation, where we release laterally, externally, and underneath, release the rectus sheath to advance it. Actually, that technique, kind of as it's described, we probably did infrequently. However, advancing the rectus muscles by doing a portion of that, and everybody describes it just a little bit different. And that's probably what we did, is we modified it just a little bit. It depended on the patient. But if I can avoid some of those big incisions, some of those big releases, I will. And it's just a matter of feeling how things advance, how soft the tissue is, how tight the patient is.
So you would just tailor it based upon
Sure.
how much you needed to release to get
Sure.
the rectus program.
But if I say we do component separation on all those patients, I just want to be clear that true component separation, probably we've modified. Not all the patients need that much release or that much advancement.
So if I'm interpreting that right, you're saying that 6% of the time you did component separations as a standalone technique.
Well, exactly.
The full thing.
As
The entire component separation type operation,
But other times you do
modified
some
some.
all of component separation reinforced by an alloderm or a mesh or something
Exactly. Thank you.